Hello, everybody, and thank you very much for joining us today. Today, we're going to be rebroadcasting a recording with Holger Sudov. Holger Sudov, if you don't know, is really the inventor of modern-day balloon dilatation of eustachian tube, a good friend and a very good speaker, and he has a tremendous amount of knowledge to share with us. He did this talk to us about a month ago, and I find that really, if you're interested in eustachian tuboplasty, you really need to hear what Holger arguments and point of view. So I'm just going to start the talk, and please enjoy.
History of eustachian tube before I'm going to discuss the indication, the surgery, and the randomized controlled studies that we're currently performing. So just let me very shortly introduce you to our to Bielefeld, which is located in North Rhine-Westphalia. We have a population that we serve of about 2 million people, and this is the historic marketplace in the city center of Bielefeld. And so that's where actually we started to develop balloon dilation. So just looking at the eustachian tube, and I think all of you know for a long time the eustachian tube itself has been a black box of otology. This is pretty much related to the history and that we didn't have any appropriate measurements, no appropriate therapy. And so I remember when I was a junior doctor in my old department working with Henning Hildmann in Bochum, he always told me, never touch the eustachian tube, you can only make it worse. And so it's difficult to define. Let's take a look, what is a eustachian tube dysfunction and how can we define it, what kind of strategies can we apply? And we need to actually be aware of the fact that there are many different pathologies that are related to the eustachian tube dysfunction. So we just don't have a single underlying pathology. You may have allergies, reflux, chronic rhinosinusitis, or other diseases that contribute to eustachian tube dysfunction. And this is expressed by the fact that there are a lot of different tests, but no single test is working for all the conditions, and which is not new to ENT. We have poor data, so we don't have much on randomized control or level 1 or 2 evidence so far. That what we have, I'm going to discuss with you later on. So looking into the anatomy, and I'm just very shortly going to discuss that with you. We have the eustachian tube, which is actually composed out of a bony and a cartilaginous portion. This is the nasopharyngeal office of the eustachian tube. You can see the diameter is changing. This would be the isthmus region of the eustachian tube. And the bony portion is just a very rigid construction, and whatever we do in this area, I wouldn't advise you to do surgery on this part because you have a proximity to the internal carotid artery, as you can see here. All the muscles attached to the eustachian tube, so the tensor tympani, the muscles like the levator veli palatini or the tensor, are attached to the cartilaginous portion. And we have learned over time that this is a highly regulated structure. And so I think the prime goal, if we do anything to this structure, needs to be the cartilaginous portion. And my friend Dennis Bowe from Boston Children's Hospital and me and other colleagues and Moaz himself actually worked on that very carefully. So let's take a look at the opening of the eustachian tube. And Dennis Bowe kindly supplied me with this very well instructive video. And you can see in slow motion endoscopy how the muscle function, like the tensor, levator, are working. And it's an air bolus that is traveling through the eustachian tube. And you can see the dynamic and the assembly of the whole structure that is really complex. And now the eustachian tube is never open through its whole length. So you can see an air bolus traveling to the eustachian tube. You can see the muscle attached to that and their activity. So very briefly, let me comment on the function of the eustachian tube. Of course, it serves pressure equalization on both sides of the tympanic membrane. It's going to ventilate the middle ear. So we have two functions in terms of ventilation. We have gas exchange, and as you know, nitrogen oxide is traveling much slower. You're all aware of Caisson's disease. So due to the fact probably that we need a pressure adapter that is filled with air, we need to be able to equalize pressure and we need to ventilate it. And I personally see the eustachian tube as a kind of pressure ventile that is going to help additional to the process of gas diffusion through the middle ear mucosa. Of course, we have a lot of cells in the middle ear. Look at all the goblet cells, and the mucus needs to be discharged, and secretions are actually cleared via the eustachian tube. And of course, we need to protect the middle ear. Think about the incidence of otitis media, especially in children, but not only from pathogens, but also from sounds. And sound, of course, if it's open and we're talking about a patulous eustachian tube dysfunction, then it has a huge impact on the quality of life of a patient. So initially, we met with a couple of colleagues from around the world in Amsterdam, and we tried to look into this paper, Eustachian Tube Dysfunction, Consensus Statement on Definitions, Types, Clinical Presentation, and Diagnosis. So we met, we discussed with a lot of expert colleagues on this issue, and we came up with a paper that I would like to share with you. And the main idea is that we can distinguish three different types of eustachian tube dysfunction. Dilatory eustachian tube dysfunction, which can be subdivided into a functional obstruction. This is the most relevant clinical part. A dynamic dysfunction, think about patients with cleft palates that are unable, and if you would do a slow motion video endoscopy in those patients, you wouldn't see any opening of the eustachian tube. And very rarely we find an anatomical obstruction. So sometimes you can see this in rare cases like osteopetrosis of the temporal bone, in Paget's disease, or in other diseases where you have a bony ossification, but this is really rare. And on the other side, there is a Barrow challenge-induced eustachian tube function, which we see in flight attendants, for example, in patients doing a lot of air traveling or divers, where the eustachian tube dysfunction is clearly related to the ambient pressure. So some of my patients, they can tell me I can dive up to a depth of about 8 meters, and I can't do any, then I get into trouble. Or patients that are doing air traveling or flight attendants, they will let you know. And then we think about another eustachian tube dysfunction, which is a patulous eustachian tube dysfunction, which has been described by Jabo in 1840 years early, and by Schwarze from Halle in 1851. And this eustachian tube dysfunction can be either chronic, permanent, or intermittent, or masked. My friend and colleague Kobayashi from the Tohoku University Hospital in Sendai, he actually termed this masked eustachian tube dysfunction. And if you put in a grommet, for example, or if you reinforce the tympanic membrane, you can actually mask signs of patulous eustachian tube dysfunction. And sometimes if you have an underlying eustachian tube dysfunction that is patulous, and you do a wonderful ossiculoplasty and the hearing is going back to normal and you have closed the air bone gap, then the patient may complain. Talking about complaints like I hear my own voice, and that can be really nasty and has a huge impact on the quality of life of a patient. So this is actually the first person that I'm aware of is Alcmaeon of Sparta in Greece, who actually described and thought the eustachian tube would be a central organ for communication and nervous perception. And he postulated that it's essential for respiration. On the other hand, it was Bartolomeo Eustachius who actually gave the first anatomical description of a couple of structures like the middle ear, cochlea, thoracic duct, or uterus. And he identified that the eustachian tube is a passage between middle ear and nasopharynx. And he gave his first reports on the eustachian tube physiology in his very famous paper, Epistola de Auditus Organis. On the other hand, it was Antonio Maria Valsalva, you're all aware of the Valsalva maneuver, who actually postulated that the eustachian tube is an essential organ for drainage of the middle ear, and the Valsalva maneuver is named after him. On the other hand, it was Joseph Toynbee who actually, for the first time, described a technique. If you look at the temporal bone collections around the world, in Boston or at the House Group or in other places, you hardly find any eustachian tubes. So normally, if you take the normal approach to harvest the temporal bone for example, for middle ear surgery training, you remove the eustachian tube, and it needs a different kind of dissection to remove the temporal bone with the adjacent eustachian tube that he described, and he also identified the eustachian tube muscles. So he actually tried to cure his tinnitus, and accidentally this picture was taken in St. Mary's Hospital in London by his wife, and he tried to cure his tinnitus and accidentally passed away by a lethal combination of prussic acid and chloroform. So that was very tragic. However, he did contribute a lot to otology, and he was one of the outstanding pioneers. Again, there was a professor from Germany, Rüdinger, who described here in the superior portion of this inverted shepherd's crook, which is like an inverted J. You can see this area up here, and this is called Rüdinger's safety channel, which is thought to be a patent, but you can see some valves here and the muscles attached to this. The superior portion of the eustachian tube actually is contributing more to the gas exchange, and the lower portion is very relevant for drainage function. So you have a functional compartmentation within the eustachian tube that has been described by Rüdinger in Munich. Adam Politzer, of course, he is one of the giants in otology, and he described the Politzer maneuver and actually assumed for the first time that the eustachian tube could contribute to otitis media, to chronic otitis media. And you know that we still have a lot of debate on that, but I think he was the first one actually to suggest that. If we look at other clinical signs and symptoms of eustachian tube dysfunction, what do our patients report? And that can vary a lot. So majority of patients with ambient pressure eustachian tube dysfunction will discuss that if they are exposed to different ambient pressures. Most of them can't do a Valsalva maneuver, but please keep in mind that about 4% of the patients can't do a Valsalva and will never develop any ear pathology. So an obvious group is chronic otitis media with effusion, middle ear atelectasis, recurrent ear diseases, and failed tympanoplasties. Just seen a patient today operated elsewhere where the prosthesis was extruding. So this is due to the negative pressure, and I'm going to give you some examples on that later on. So it's absolutely necessary, apart from taking the patient's history, to do an endoscopy of the nasopharynx. And you will be amazed what kind of symptoms you can see. Look at the upper left picture. Here you can see strictures. There are adhesions. This is a post-adenodectomy case. And we use a Beckman's ring knife, and you can see the scarring. Here you can see a cyst that has an impact on the opening of the eustachian tube. You can see some pus discharging through the eustachian tube, and you can see this cobblestone pattern in the inferior right, which is typical for reflux. And what you see are these little adhesions, for example, and they have an impact. So I very carefully, besides doing the balloon, look for those pathologies and try to actually get rid of them. Of course, we do our endoscopy, or we use a microscope to do the otoscopy, and you can see a middle ear fusion or here retraction. Some of these retractions, if they are fixed, we are unable to clear with a balloon. So if that is actually, if the patient is doing a Valsalva, I think, and there is no fixation of the retraction towards the promontory or the incudostapedial joint, then we have a good chance of clearing their symptoms. So initially we were really scared because you're aware that the Danish king, or the private doctor to the Danish king, actually died when someone tried to use a metal bougie. And when I did the first case, we were a little bit worried. So initially we did a preclinical study. Is it feasible? Is it technically applicable to use a balloon? Is it safe? Are we going to damage structures like the internal carotid artery? And if we use a balloon, are we able to reverse that? And are we going to improve the eustachian tube dysfunction? And so we had a lot of questions initially and had no answers. So we tried a cadaver study, and I show you our first device, which was a maxillary suction tube and the balloon, and this is a pressure syringe, and we punctured the pharyngeal office of the eustachian tube, and it worked really well. And so we thought, you know, that may be a technique, because as you know, decongestive nose spray doesn't have an impact on the eustachian tube, and it's not going to have any benefit for the patient. So we were really relieved when we saw that. And then I filled the balloon with contrast dye, as you can see on the left CT scans. And we tried to rupture the internal carotid artery. However, the pressure, and my colleague from the Ulm Armed Forces Hospital calculated the pressure, even if you blow up the balloon to 25 or 30 bars, it's not going to rupture the internal carotid artery. This is a 3D reconstruction of the DICOM data set of the balloon placed in the bony portion of the eustachian tube. So again, this is showing you a temporal bone study, and you can see the eustachian tube. And if we go from medial to lateral, in the very lateral portion, think about the bony office of the eustachian tube in the middle ear spaces, you have a very close proximity towards the eustachian tube and the internal carotid artery. Generally, you have some air cells around that can be troublesome, for example, in translabyrinthine acoustic neuroma surgery, but you have a very strong proximity, and it's very close, so we needed to make sure that we're not doing any damage to that. initially, and this is a cadaver study, which is probably not quite valid, but I would like to show you that to you. You have a mucosal lining, and if you put in the balloon, of course, you get wider airspace. These cracks probably you don't find in patients because the elastic cartilage. This is probably a post-mortem change in a cadaver temporal bone with the eustachian tube. But you probably shear off, and the biofilm, and Dennis Poe from Boston Children's Hospital worked on that very substantially. Going to show you some of his data later. So, but what do you do? And there is a guy, I think he's now working in southern parts of the US, McCool, who actually developed this questionnaire, the EDTQ-7 questionnaire. It's probably not a tool that is very scientific, but it's something that helps you to stratify those patients. It helps you, even if you don't have any testing around, you can ask these seven very simple questions, and they're going to help you to stratify that. It's not 100% safe, but to actually narrow down the diagnosis, it's really helpful. So we came up with a technique that has been developed by a French physiologist, Esteve. I'm just showing you that very briefly. You have the nose piece here, and it's going to put air up into the upper airways. It's going to open the eustachian tube, given its patent, and the increased pressure is going to displace the tympanic membrane, and this is recorded by a pressure probe. And so it's actually done while the patient is going to swallow water. And then you can see the swallowing function, the active and the passive opening of the eustachian tube. I think it's a very simple, very reliable, but not the only tool you should apply to stratify and to narrow down your diagnosis. So again, here's the setup, the nose piece, the trigger, while the patient is going to swallow, and we apply 30, 40, 50 millibars and record the tympanic membrane. It needs a lot of experience. So we've done, I don't know, about 50 or 60,000 tests by now, but the problem is really you need to seal it tightly, the ear probe. You need to have some experience, and you need a technician helping you with that. And you record the pressure changes in the external ear canal. What you can see here, the upper curve is showing you the pressure changes while you swallow. Normally, we swallow, an air bolus will travel through the eustachian tube, and you can see the rise, which is parallel to the swallowing function. And we get, of course, information on the swallowing maneuver, tubal patency, the latency between C1 and P1 would be the latency of the eustachian tube opening. And of course, if you look at P3, air removal from the middle ear spaces. So the eustachian tube can be blocked in one way or the other way. And sometimes you can see what we clinically identify if the tympanic membrane is displaced outwards. You can see that, and sometimes there is a delay in air removal from the middle ear spaces. And you can actually calculate different data. So what is the pressure changes? And the opening latency index, R, is the most important thing, showing you if there is a regular, a delayed, or no opening of the eustachian tube, dependent on the calculation. So looking into that, we tried actually to develop a eustachian tube score because there are different tests, and we wanted to objectify eustachian tube function for our testing and for our therapy. So we actually started with the ETS-5, where we had this equalizing pressure through swallowing, positive for salver, and the tubomanometry combining at 30, 40, and 50 millibars. And the maximum would be 10 points. If you keep that in mind. It's going to help you to interpret our data later on. But then my colleague, Stephanie Schröder, actually added 2 points which actually helped to increase the sensitivity and the specificity of the test to 96%. So it's a positive objective observer where the doctor actually is able to identify the tympanic membrane, and tympanometry. And with all these points, our sensitivity and specificity increased from about 85, I think, to 94%. And I would like to show you here the ETS5 results, ETS7 results in healthy cohorts and patients with the chronic dilatory eustachian tube dysfunction. And this is showing you the range. There will be 10. And healthy subjects generally have a good outcome with the ETS5. But you can see there is a range and a cutoff level of about 3–4% that have a bad outcome and a bad measurement and still don't have any problems. So these are the patients that can't do a Valsalva but will never develop middle ear disease. You can see the range. The mean dropping from 8.9 to 3.3 in the pathologic group. And if we add the 2 items that Stephanie Schröder introduced, you can see a drop of the mean value of 12.5 to 4.54. And this is giving you a good cutoff level, which is about 9, to stratify the patients for therapy. So how do we do balloon dilation? And it's pretty simple, but it can be challenging and tricky. So we puncture the office of the eustachian tube. We insert the balloon up to a level of about 2 centimeters, and then we inflate the balloon. The balloon is filled with saline, and this is going to skip, because we use a balloon, we don't have any shear forces. If you would insert a rubber bougie or whatever kind of bougie, you would have shear forces. And I think why it's working is really due to the design of the balloon, which is there are 3 different companies on the market, but this especially doesn't have any shear forces, and it's going to have good reproducible results. I would like to very shortly to take a look at the balloon. There is a tip. The tip is now much softer, and you have the balloon. It's a balloon that is inflating in width. So normally the dimensions are 3 to 20 millimeters, but at 10 bars, the width is going to be 3.3 millimeters. You can see the syringe with the filled-in saline, Lurlich system, and you can have 10 bars. That's what we've actually found to be sufficient for the patient for balloon dilation. There are 3 different techniques. I'm going to discuss the adult techniques with you first. You use a Hopkins optic. Let's say we would like to dilate the left eustachian tube in this patient. So you take a 70-degree angled Hopkins optic, you put it back to the nasopharynx. The balloon, the introduction device, is angulated into the office. And I personally prefer this contralateral approach because it gives you more freedom to handle your instruments. On the other side, if the nose is wide enough, you can actually use a 30-degree Hopkins optic. You can insert it, you can dilate it, and then you can work on that if given you have enough space. What is helpful sometimes, and I really like this technique, is if you need to do eustachian tube surgery and you want to actually create a new office of the eustachian tube, or if you have huge pathologies, you can see here there is some looking like a lipoma here in the back of the nose, or excess lymphoid tissue. You can actually see a lot of pathologies if you look very carefully. But if you do the technique in velotraction and you go with the endoscope via the mouse and you insert the insertion device via the nose, you can actually use the symmetry between both offices of the eustachian tube to have a good approach. And it's sometimes, if you have bleeding, it's going to facilitate your approach. This is the insertion device by Spiegel and Theis, and you can see the different angulated instruments. And I prefer the 70-degree because it helps me in most of the cases, and I hardly can remember that I need to change it, needed to change it to a different angulation. So this is the operating table. We generally do the procedure in general anesthesia. There is a Finnish group doing it in local, but it takes more time, and it's probably not the most pleasant experience for the patient. You need to, what we do before we put the patient into sleep, we use decongestive nose spray, and then we put in this these soaked cottons into the nose. You can use, in adults, you can use cocaine solution in a small dosage, which is really helpful to prevent bleeding, but it's not necessary in most of the cases. And here is the syringe, the balloon that is coming in this coiled setup, the different insertion devices for children and for adults, and the different angulated endoscopes. So just very shortly showing you the introduction that has been done by Thorsten Ockermann and my former MD student. And you can see the opening of the eustachian tube. And now we're going with this insertion device, which has a camera attached to that, into the office of the eustachian tube. And you can see the mucosa opening up. You can actually identify little polyps here. You can see the mucus on the inferior portion. And the superior portion would be for the gas exchange. So that was the first video done, and is my former MD student who is playing his guitar. And then you can see, again, it's looking like a rigid esophagoscopy. And then the balloon is inserted. And I think it would make sense to work on different endoscopes that we are able to. Here you can see the balloon inserted, and of course once it's inflated it's going to obstruct the vision. But what we generally do, and I would like to show that to you, is we actually position the microendoscope before the catheter insertion. Here's a severe septal deviations can be a problem. Just take your time, stay on the inferior portion. The insertion process is not a big problem generally. You can see that here, we puncture it. Sometimes you can actually use the very tip of the insertion device to actually free the office a little bit. And then we retract it. Make sure that you deflate the balloon, and then you can see the balloon in a non-inflated way. So that is actually the technique. It's very simple. Just to show you a paper that we published in Clinical Otolaryngology is the ETS-5 score prior to the balloon, 2 months, 1 year, 2 years, 3 days later. And what we see was a gradual increase of the ETS score due to a better ventilated middle ear. So we don't, sometimes we have an effect straight in the recovery room where the patient would tell you, well, everything is better now. Sometimes you can see this prolonged healing period, and you need to to inform the patient that it's going to be better for like the next worst for the next 2-3 weeks. And then there will be an increase in the eustachian tube ventilation, and an improvement of clinical signs and symptoms. In children, we have quite a lot of experience. We just got one randomized controlled study with 16 centers in Germany accepted by otology neurotology that will be published soon. It's easy to do that in children with smaller insertion devices. And if it's difficult, if there are a lot of adenoids, which you have to remove, of course, as well, velotraction is a great technique to get a good visualization of that area. This was an early study from 2017 with my colleague Matthias Tisch and Hannes Meyer from Ulm and me on children, 126 children. And it's really interesting because the children, we just asked the parents, would you recommend this procedure to your friend, or would you have to done? Would you allow a second procedure? And more than 90% of the children, of the parents, showed an improvement. And it was found that it's, and these have been children that never responded to conservative treatment that has 2 grommet insertions, so very negative group of patients. And then just recently we have this paper 2017 by my friend Dennis Poe, who actually showed in this wonderful paper in Laryngoscope that balloon dilation is superior in the medical as compared to the medical management alone to treat eustachian tube dysfunction in adults. That was really helpful. And then there have been other papers by Ted Meyer's group, for example, from the University of South Carolina in Charleston, actually proving that balloon dilation is superior to continued medical management for persistent eustachian tube dysfunction. So we have 2 randomized controlled studies. And I just want to show you a couple of others are coming up. This one was from 2018. And here you can see one of my patients showing an improvement of the air-bone gap just due to negative ventilated middle ear with an improvement in the hearing outcome, closing of the air-bone gap and a normalization of tubomanometry showing an improvement. Of course, always we have to look for other pathologies. And this is a patient with a chronic rhinosinusitis. You can see the mucus discharging, obstructing the office of the eustachian tube. And with all these cytokines that are released there, you can, it's easy to imagine that you have a blocked eustachian tube. Other thing is reflux, and this cobblestone pattern is very typical for patients. So take a look, and besides looking at the back of the nasopharynx, it makes sense to take another look into the larynx to identify those pathologies. This is a sample from a patient with reflux, and you can see the cobblestone pattern. Here you can see the lymphoid tissue of the mucosa-associated lymphatic tissue in the nasopharynx. You can see the high degree of inflammation in the subepithelial connective tissue. So what happens if we use a balloon, and why does it work? And you can see this pictures from Dennis Poe, and he published a wonderful paper on that. What you see actually is the eustachian tube office, the inflamed mucosa, what I've showed to you previously. You can see the inflammatory infiltrate in the subepithelial connective tissue. And when you inflate the balloon, and this is post-dilation, you can see that part of the superficial layers are sheared off. The biofilm probably that is persistent in this area has gone, and the inflammation has been crushed. So if you take another biopsy, I'm not going to show you the pictures, but Dennis showed me, you get a nicely non-inflamed mucosa. So there seems to be a deadlock situation made of mucus, biofilm, inflammation. And once you've cleared that deadlock situation, I think we're going to improve the ventilation of the middle ear. Not in all cases, but in the significant majority of cases. So another aspect that I would like to share with you is the pressure changes. So far, we had one case where we had a 30 dB hearing loss in one patient that I couldn't explain. So what we did, we took sheep heads and we identified the office of the eustachian tubes. This is the bulla of the sheep. The external ear canal is very long. You can see this mastoid process. And so first thing was to start to identify the office of the eustachian tube. And it's really this tiny piece of cartilage. And the balloon is inserted. This is a pressure probe from a Canadian company. And you can see the increase of pressure while we advance the balloon. When we inflate the balloon is, the pressure is increasing as well. This sensor was put into the middle ear. And when we withdraw the balloon, we get a negative pressure as well. So you need to do that gently. That's very important. But if we look at the pressures in this animal model in sheep, we looked at 10 and 26 bars of pressure increase. You can see that none of these maximum pressure related to balloon inflation, the velocity of pressure changes during balloon inflation per second, and all these values were not able to actually either rupture the round window, Reisner's membrane, or even tympanic membrane. You can see the data given here. So we're pretty safe with doing any damage with our pressure-related increase. On the other hand, what I told you, look always for pathologies. The nasopharynx, you can see here, this yellowish structure that was amyloidosis in a patient, localized. So that didn't work using the balloon. I took a biopsy, and you can see here with Congo red and polarization that it was amyloidosis, which is a localized form, but not a systemic form. On the other hand, I would like to show you that kind of surgical sample. This boy came to see me when he was 14 years of age. He had an adenodectomy at the age of 1, and a revision adenodectomy at the age of 2. At the age of 3, he developed a cholesteatoma and had 9 consecutive tympanoplasties by really experienced middle ear surgeons. But you can see when I did the number 10 revision, you can see how bent the prosthesis is. So this is the foot plate. You can see the handle of the prosthesis being completely disarranged. And how did it come? And I would like to show you those pictures. If you do an endoscopy, you can see the scars from the Beckman's ring knife in the back of the nose. You hardly could identify an office of the eustachian tube. Here everything was scarring. So one of the previous surgeons performing the either adenodectomy or revision adenodectomy removed the cartilage, and there was a complete closure. And on the left ear, the boy developed a cholesteatoma. So we can tackle the situation, but it's difficult and tricky. If we have a scar, and this patient had another procedure that I would like to show you. It's a complete obstruction of the eustachian tube after maxillofacial surgery. So this patient received a bimaxillary advancement surgery, and this was all scarred. And what you see here is that we could open it. You can see the mucus with a laser, so we could recanalize it, but you need to put in a stent, which is very important. Again, this is another patient that was really amazing because unfortunately he had a failed radio forearm flap. He had a squamous cell carcinoma on the soft and hard palate, and the reconstruction work was not successful. What you can see here is the opening of the eustachian tube. So you can see actually a relation live in that patient. And after radiotherapy, there was an obstruction. So again, we recanalized the eustachian tube. I stitched in a stent. that needs to be there for about 3 months. And after 3 months, the patient went back to regular eustachian tube function. So far, we have treated more than 6,000. I haven't updated the last numbers, but we didn't see any serious side effects of the treatment. 2 balloon dilations. We had occasional tinnitus enhancement, infrequent epistaxis, no Petlius eustachian tube, almost 300 revisions in patients that where it worked initially, and after half a year, we decided to go in for a revision, and 6 emphysemas, but the balloon was tilted and where we did injure the mucosa. I need to add one more case of a 30 dB hearing loss by now that occurred in one patient after the dilation. So this is how actually an emphysema looks like. Here you can see the air intact in the soft spaces, and you can see, but this normally clears after 2 or 3 days. Just tell the patient not to sneeze and put him on oral antibiotics, and that is going to clear the situation. So what we've seen, the rate of improvement is dependent on the pathology. And the majority of patients which have problems being exposed to ambient pressure will benefit from the procedure. Chronic otitis media, atelectasis, but if you have more substantial damage to the middle ear, the success rate goes down to 50 or 60%, and really depends, because there have been a lot of different reports on success rate, but it's dependent on what kind of patients you include to your study. So far, there have been more than 100,000 procedures worldwide. We could actually see in our cohort an improvement in about 80% of our patients after 1 to 3 years. 90% were satisfied on post-treatment. We're currently doing all more randomized controlled studies. So I hope that I could take you through this little journey of balloon dilation, eustachian tuboplasty. It's a novel technique. There have been a lot of clinics around the world adopting it, and it makes sense to use it in selected patients. Make sure that you have a patient's history being taken, that you are aware of the limitations of the procedures. Rule out superior canal dehiscence syndrome. Sometimes you may have to do a Hydrops MRI if you have a beginning of Meniere's disease, which can have similar symptoms. And if you do that properly and you follow the algorithms that we developed, and a lot of people who worked on that, like Bernard Aas, James Dyson, Moaz, you did a lot of work on that as well. And I think then you can produce a lot of happy patients and a good outcome. So shukran, and thank you very much for your kind attention.
So much, Holger. As usual, great lecture.
So thank you, guys. And this is the end of it. And tomorrow at 10:30, there will be a transmission from Cape Town, and it's going to be a minority case discussion. This is going to be the weekend for us, so I'll leave you all and have a nice evening. Thank you.